Good afternoon, everyone. I'm John Iannian, Director of the Institute for Healthcare Policy and Innovation, and I'm standing in today for Caroline Richardson, who leads our Education and Training Faculty Work Group within IHPI. And it's my pleasure to introduce our speaker today, Dr. Donovan Maust. Donovan is Assistant Professor of Psychiatry and a Research Scientist with the Center for Clinical Management Research at the VA Ann Arbor Healthcare System, where he sees patients on the Psychiatry Consult Liaison Service. He earned his medical degree from Johns Hopkins University and completed his clinical training at the University of Pennsylvania. He has two primary lines of research that are informed by his work as a geriatric psychiatrist. In work funded by NIA, he's exploring the patient and caregiver factors that drive receipt of potentially inappropriate medical care for patients with dementia. In work funded by the VA and NIDA, he's exploring the determinants and harms of benzodiazepine prescribing and identifying strategies used successfully in the VA to reduce benzodiazepines prescribing, which is the focus of his talk today. He notes that his primary extracurricular activity is asking his children when they're going to practice the piano, and he's offered to perform that service for other families within IHPI. So please join me in welcoming Donovan speaking about medicating distress benzodiazepine use in the United States. And just want to mention we'll have time for questions at the end, and after the question period we'll have a reception for everyone attending today's seminar right outside the research auditorium. Thank you, Donovan.
Thank you all very much for coming out on this very nice fall afternoon. And thanks for the introduction, John. So I don't have any conflicts to disclose. So what I wanted to do is just do sort of a kind of fast 30,000 foot view of what's going on with benzodiazepine prescribing. The specific things I wanted to talk about is just get us all to the same page around what exactly are benzos, what's going on with prescribing across the country and over time. What's exactly the evidence base for the amount of prescribing that we're seeing, especially when you compare it to the risks that there are related to benzo use? And then to think about what are actually the things that are driving the prescribing? Is it about the patient? Is it about the provider that they see? Is it about where they live? And finally, what do we actually know about the interventions that are out there to try to reduce use? So a lot of ground to cover to get us to snack time. Okay, so what are benzos? So they're things like Xanax, Ativan, Klonopin. They have 5 primary actions. So they are anxiolytics, so they reduce anxiety. They are hypnotics, they make you a little bit sleepy. They're muscle relaxants, anticonvulsants, so they stop seizures, and cause amnesia, or they impair memory. It was kind of a big deal when they came out in the late 50s, early 60s, because they replaced another type of sedatives called barbiturates, which if you take a little bit in an overdose are fatal to take. So it was actually a big development that we had this class of medications that were actually much safer than barbiturates, which had been used for similar reasons. Okay, so when these medications first came out, there were fun ads like this. So this is a poor housewife who's trapped in a cage of brooms, and you can't read the text, but it says, beset by the seemingly insurmountable problems of raising a young family and confined to the home most of the time, her symptoms reflect a sense of inadequacy and isolation. Your reassurance and guidance may have helped some, but not enough. So give her Cirex, give her benzo. Okay, so then, and even another ad that I really enjoy is this one. So it's basically saying, this patient you're seeing who looks more like a man is inaccessible and he's not a good talker. And so basically, if you have him pregame with a benzo, with Librium, he'll be more chatty and you'll have more effective psychotherapy with him. So these were how these medications were marketed when they first came out. Okay, what exactly do benzos do? So they enhance what's called GABA, which is an inhibitory neurotransmitter. Something like 40% of the synapses, or the connections between neurons in your brain, are GABA receptors, so which is the most common neuroreceptor. So basically GABA sort of puts the brakes on or turns the volume down on the excitement that's going on in your brain. And so benzos basically boost that activity that's naturally going on. So they vary on 2 key features: on potency, so basically a tiny amount of Xanax is worth many more milligrams of oxazepam, which is called Cirex. And then they also vary on half-life, meaning how long they're active in your system. So Xanax, again, has a very short half-life compared to diazepam, which is also known as Valium, which has a very, very, very long half-life that it's exerting its effects in your brain. Whoops, wrong button. So they are considered DEA Schedule 4, which is considered low potential for abuse. Providers can prescribe refills, but there's only a certain number of refills allowed within a 6-month period of time before you have to have a new prescription. And I think most people would agree that alprazolam or Xanax has the worst potential for abuse, and I think that's specifically because of this combination. So it's both high potency, so a tiny dose has a big punch, and it has a short half-life, which means it doesn't work very long. So you take it and you feel the effect, and then it goes away. And then that makes you want to take more so you can feel better again, and then it goes away. So you can see how the doctor prescribes it for twice a day, and you suddenly think, oh, I would feel better if I took an extra dose and added a dose in the middle of the day. The other really tricky thing with benzos is this is physiological dependence. So basically your brain gets used to constantly seeing this level of essentially sort of boosting the brakes, lowering the activity. Your brain gets used to that after a while. So then suddenly if you take it away, that can become very uncomfortable. You can have a return of insomnia, you can have a return of anxiety, physical symptoms, tingling, GI distress, nausea, and at the extreme, you can actually have seizures. So you could imagine if you've been on these medications for years and years and years and you take them away, suddenly the electrical activity in your brain sort of goes haywire. So you can have seizures, and these are potentially fatal. So taking someone off of a benzo is not a trivial matter. So whereas opioids, stopping someone's opioids can be very, very uncomfortable, and conceivably if they have so much diarrhea and so much vomiting, they could have like electrolyte abnormalities and die from those. It's actually very unlikely that opioid withdrawal would cause mortality, whereas benzo withdrawal you definitely could die from. Okay, so some basics of the epidemiology of benzo prescribing. So this is an analysis from a couple years ago. So right here we have age on the x-axis, so 18 years old to 80 years old, and you see use just goes up in a straight line. So the oldest adults have the highest rate of use. Women have about twice the rate of use of men. That starts here at 18 and it continues all the way up until the end of the age range. Okay, so part of the reason I think that use goes up with age, this is a paper of mine that we did with something called NAMCS, or the National Ambulatory Medical Care Survey. So basically what you see in the light gray by age group is the rate of new starts of a benzo. So that's not really going up so much that there are a lot of new starts with age. What is increasing are the dark gray rectangles, which are continuation. So people say out of every 10 people who get started on a benzo, some group of them will continue on it and go on to become long-term users. And so if this process starts at 18 years old, you essentially gradually have this accumulation of chronic users, which I think largely accounts for why older adults have a much higher rate of use. Use is increasing over time. So this is from a different survey. In the graphs, they have it broken down by age, but the overall numbers are down here at the bottom. So this is adults filling a prescription between 1996 to 2014 went up to 5.6%. This is basically about the total amount of medicine out there, and it's a super bizarre unit. So these are kilograms of lorazepam equivalent per 100,000 adults. There's like no good way to think about what that means other than to know it. Essentially the amount of benzo out there in circulation more than tripled per person in the population. So the number of people on didn't go up that much, the amount that's out there more than tripled. And then overdoses have gone up, that has gone up like 6-fold till 2014. So 2 slides ago, we talked about the distinction between new and continuation use. And so this analysis is basically showing that over time, new use has not gone up so much, but it's really this continuation use that is growing and growing and growing. This study was from 2005 to 2012. Okay, so we've talked a little bit about what benzos do, who's getting them, what's it looked like over the past 10 years or so. So what's so bad about benzos? Why is this guy talking to me for like an hour about this topic? Okay, so there's literally decades of evidence about benzos increasing the fall risk, particularly in older adults. One of the first big papers was in JAMA, now over 20 years ago. This is a meta-analysis that was from about 10 years ago, specifically looking at fall risk. And when you pool the various studies that have done it, it increases your risk. So 1.6, or about a 60% increase in the odds of a fall if you're exposed to a benzo. Okay, motor vehicle accidents. People don't think about this as much, but it's actually a similar risk to the fall risk. So this is from another meta-analysis where the top group is from case control studies and the bottom group is essentially a different type of study, a cohort study. And again, the increased risk is about 60%. Interestingly, this is less pronounced in older adults. So maybe it's that there's sort of competing risks for auto accidents in older adults, maybe who are experiencing some cognitive impairment or functional impairment. So the increased risk of motor vehicle accidents for older adults is actually around 1.4. So it's higher for younger people. Overdose deaths. So benzos are the number 2 prescription medication and pharmaceutical overdose deaths after opioids. They're involved in about 30% of all overdose deaths. If you look at opioid overdose deaths, about 30% of those patients were prescribed benzos, and Amy Bonnert here and her group has done work showing that that's a dose-response relationship. So people who are on any benzo, who are on an opioid, and any benzo are at a higher risk than people who are on the opioid alone. And as you increase the dose of the benzo that's prescribed, that risk goes up. And then if you look at benzo deaths, about almost 80% of them are co-prescribed an opioid. So benzos are very much part of the opioid epidemic, and you can see here what's happened to overdoses with opioids. Interestingly, I noticed that actually the male overdose line is higher, which is sort of surprising since we know that women get prescribed at 2 times the rate. But the point is that benzos are very much part of the opioid epidemic. They're almost a bit like they're fuel for the opioid epidemic, but there are still overdoses that don't involve opioids. Because of this, in August of 2016, the FDA added a black box warning which is like their highest warning for prescribers about the combination of opioids plus other CNS depressants, and the biggest medication family in that group are the benzos. Okay, so finally, impaired cognition. So there's a mix of evidence around whether or not benzo exposure is associated with a higher risk of developing dementia. What there really is not controversy about is actually cognitive impairment. So you'll remember that on the list of the things that benzos do, amnesia or memory impairment was number 5. This is why benzos get used for procedural sedation, so you don't remember having the procedure. Geriatrician up in Canada did a systematic review and meta-analysis of placebo-controlled studies looking at the cognitive effects of benzos, and this is a quote from that study. In studies of short, intermediate, and long-acting benzos, these drugs consistently induced amnestic or memory-impairing and non-amnestic cognitive impairments with evidence of a dose-response relationship. So when you think about the fact that for older adults, one of their greatest fears is memory impairment, cognitive impairment, and so like to over 10% of adults over 65, we are prescribing them medications that have been demonstrated to impair their cognition, is just pretty bizarre. It's just really odd. Okay, so wow. This is what the amount of use in the population, given all of those risks I just told you about, there must be really compelling clinical reasons to justify this amount of benzo prescribing in the US. And that is just not true. So I'll walk you through that evidence. Okay, so this is, again, using this National Ambulatory Medical Care Survey, where basically they survey they pick doctors who represent all doctors in outpatient practice in the United States. So I'm a geriatric psychiatrist, so my focus is usually on adults 65 and older. And I don't mean to pick on non-psychiatrists, because psychiatrists do lots of bad prescribing, but in general we know that the vast majority of prescribing is not done by psychiatrists. So that's why I'm not focusing on them. So if you look, this is a study where we looked at people who were continued on benzos versus who were on a new benzo. So my thinking is, okay, if a patient gets started on a new benzo, there's probably like a good clinical reason, diagnosis indication that they're getting prescribed a medication. And as part of the survey, they collect diagnosis information from the doctor's note. So, what's the problem list in the note? What's the doctor trying to address during that visit? So again, a visit, older adult, new benzo, about 20% of patients had a diagnosis of anxiety, 11%, a little more, had insomnia. Any mental health diagnosis is 40% of patients, which means like 60% of patients who were prescribed a new benzo didn't have any type of mental health diagnosis or insomnia in their chart. So you could say, well, so anticipating the reviewers of this manuscript, you might say that's a flaw of the survey. Older adults have many diagnoses. The diagnosis that the doctor was addressing just didn't make the cut to be included in that particular survey. So we turned to an older study that was done out in group health in Seattle, and they looked at older adults who were newly started on a benzo in primary care, and they actually did a chart review to look at what was the indication documented for this medication that they started. And so this is the list. So first, hopefully you'll agree with me that we should cross off no indication given as an appropriate indication for a benzo for an older adult, and that was like 15% of people. Situational stress, we'll talk a little bit later about why that's not a great idea. So back pain, neck pain, headache, other pain. So maybe some providers would say, so for like acute muscle spasm, whiplash type of situation, you might prescribe a benzo, but in general for like headache, chronic lower back pain, there's not great evidence for benzos. And so that depression is another reason. So sort of in clinical lore, you hear this idea that when you start antidepressants, they can be kind of activating and people can feel a little uncomfortable. So the idea is if you start a benzo at the same time, it sort of helps them feel better through that initial phase, and then you can take off the benzo and the patient's doing better on their antidepressant at the end. So in the past year, there was a study in JAMA Psychiatry where they actually looked at patients who were started antidepressants, and they looked at patients who were started on an antidepressant and a benzo at the same time. And that group who got the benzo, they didn't do any better 6 months out than the people who just got the antidepressant. So we're going to take that off the list. So that leaves you with anxiety, insomnia, and counting for less than 50%. Those are the things that we would consider appropriate use of potentially appropriate use of a benzo. So now let's look at the actual evidence for that. So this is a systematic review and meta-analysis looking at benzos for panic disorder that was done over 20 years ago. So the largest effect is from therapy, cognitive behavioral therapy alone. It's also the best at maintaining improvement in the long run. And if you look at the effect size, basically it's almost 0.9, which is like a really, really big effect size. These are very effective psychotherapies. Benzos are no better than antidepressants. If you look at PTSD, so last year, practice guideline came out from the VA and the Department of Defense. It's not even like a maybe, it's a strong against due to lack of evidence for effectiveness and risks outweigh potential benefits. And then there's this interesting little bit down here about preclinical evidence suggests benzos may interfere with the extinction of fear conditioning and worsen recovery from trauma. So let me give you an example of what that means. So like 2 weeks ago, I was at a work dinner with Samir Saini, who, if any of you know him, he rides bike to work and a car hit him and he fell and he broke his forearm. So at dinner he was saying how he, the first time he went to get, his cast was off and he went to get back on his bike. And he like really was kind of anxious and a little bit fearful the first couple of bike rides he took. And then things settled down and he felt fine. What they're saying here is that, so basically that process of feeling anxious and then with repeated exposure to your bike and not getting hit by cars, hopefully, that fear goes away and things go back to normal. So what they're saying here from animal studies is basically when they take an animal, expose it to a traumatic event, and then give it a benzo, it actually doesn't essentially lose that fear response. So when it encounters, say its little mouse bicycle, it would continue to freak out and be really nervous and anxious. And so the idea is that in humans, if Samir's doctor had gone to see his doctor after the accident and said, man, I'm really nervous when I see my bike, when I try to get on my bike, and the doctor was like, oh, let me just give you a small dose of a benzo, that in fact probably would have worsened his recovery and meant maybe he never would have gotten rid of that fear he had when he saw his bike again. So the idea of giving a benzo after someone has a traumatic event probably is actually limiting the likelihood of their full recovery from that trauma. Okay, finally, benzos for generalized anxiety disorder. This is from a paper in 2011. So the only benzo that even had enough trials to include in the study was lorazepam. It was ranked last because of poor tolerability and people withdrawing from the study. So that's our evidence base for benzos for anxiety disorders. The academic detailing service at the VA does these really amazing educational materials for providers. The point of this is not for you to make out what all of these cells are saying. The point is that each column is a different anxiety disorder. Each row has the different evidence-based treatment options for those orders, and none of those are benzos. So many treatment options for anxiety disorders, none of them are benzos. Okay, what about insomnia? That's the other reason we think of prescribing benzos. So just picking a couple studies that I promise are representative, I didn't cherry pick these. So this one is from over 20 years ago, where they basically compared a benzo to cognitive behavioral therapy for insomnia. So basically the medicine helped right away, but when they stopped the medication, the sleep problem returned. Behavioral treatment, the therapy took a little bit longer, but patients did better in the long run. So this study actually compared therapy by itself to therapy plus medication. Again, the patients who got the medication felt a little bit better, a little bit faster, but when you looked in the long run, the patients who still could take medication as needed did not do as well. Their sleep was not as good as the people who had therapy alone, even though they both had therapy and the medication. So again, it's this idea that something about the medication is actually working against the therapy. It's working against the learning, the new learning that you're doing. So I'd say even more so than for anxiety disorders, psychotherapy really very clearly is the best option for insomnia. Just briefly, so I think when a psychiatrist says psychotherapy, people's mind goes to like sitting on the couch and talking about your mother. So I just want to briefly talk about what CBT for insomnia in fact looks like. So it's not rocket science, and I don't mean to be dismissive about the skill set that you need to deliver good CBT for insomnia. What I mean is that hospitals and healthcare systems are phenomenally good at delivering incredibly sort of technology-intense, high-resource interventions for patients. So it is just bizarre that it is so hard to deliver something that really is relatively simple and could help so many people if it was more widely available. Just to help people understand what the basic components are. So this is a paper, it's basically a review of CBT for insomnia, and they had a table in the appendix that said, like, these are the studies that we considered as providing CBT for insomnia. So it includes stimulus control, which basically means the bedroom is for two things. It's for sleep and for sex. It's not for discussions, like long involved discussions with your partner. It's not for watching the news. It's not for looking at your phone. It's for sleeping, and that's it. Sleep restriction, so when you're in bed, you should be asleep. When you're asleep, you should be in bed, and that's it. You shouldn't be in bed ruminating about the fact that you can't fall asleep. You're trying to train your body that you sleep when you're in bed. The cognitive part is basically helping people not catastrophize and think that it's the end of the world if they have a couple nights of bad sleep in a row. And then there's some sort of bells and whistles, so sleep hygiene is things like no caffeine late in the day, no big meals late in the day, have a coolish bedroom, and then relaxation training. So those are the basic components of CBT for insomnia. This is a great app that I would highly recommend to everyone called CBTI Coach, available on iPhone and Android. And so it really like walks you through what is CBT for insomnia, lots of excellent education, goes through things like worrying in bed, watching the clock, napping, which works against you. You actually have a record where you can keep track of when you got in bed, when did you actually go to sleep, and it graphs it out for you so you can see, like, are you actually limiting your amount of time in bed to when you're asleep or not. It's available for free, developed by investigators in the VA, Department of Defense, and Stanford. So I really would strongly encourage it to all of you to check it out. Some ambitious providers might even like learn a bit from it and use it in their discussions with their patients. The other thing is actually here we do have CBT for insomnia available to patients. So you can put in a MyChart referral for behavioral sleep medicine. and they offer it at 4 different locations. So we're actually fortunate here that we can offer this to our patients. And I'll also say that the VA, it's available widely as well. Okay, so this is a slide we had a few slides back about all the potential harms for benzos. I think the thing that really exacerbates and compounds all of this is that basically there are equivalent, if not better, treatments available for the main things that benzos are used for that don't have any of these risks. It would be one thing if we said the only treatment that we have for anxiety disorders or the only treatment that we have for insomnia is to give someone a benzo. So that would be one thing. That is not the case though. We have many, many other treatments that are in fact better than benzos, which makes it a little bit hard to say like these are acceptable and those are okay. Okay, so the talk is medicating distress in the United States or something like that. So where does that piece, where does that come into this situation? So there was this case in Deaton paper that sort of got a lot of press a few years ago where they were talking about this crisis of midlife morbidity and mortality in white non-Hispanic Americans. And so if you look over here on the right, you can see so lung cancer deaths are going down, diabetes is pretty flat, but poisonings way up, suicides up, chronic liver disease up. And so they say there's declines in self-reported health, mental health, increasing pain. This all is pointing to increasing midlife distress. And then in the discussion at the end, they say many in the baby boom generation are the first to find in midlife that they will not be better off than were their parents. So just to remind folks in the audience, baby boomers were born 1946 through 1964. So that means if you're 54 to 72, I'm talking about you, you don't have to raise your hands. So somebody actually, there was a paper a little bit before the case in Deaton paper that I think also was getting at this. So this was actually done using the Health and Retirement Study. And it was published in the National Bureau of Economic Research working paper. So they actually used sort of the first cohorts in the health and retirement study. So the original group was born in 26 to 41, what they called the war babies, 42 to 47. We might disagree about whether or not they should be in the boomers or not, but for this paper then the third wave were what they called the early baby boomers, starting in 1941. So they essentially had 3 successive cohorts of older adults who were surveyed when they were in their early 50s, which they called sort of on the cusp of retirement. And so this is what they write. So boomers indicate they have relatively more difficulty with a range of everyday physical tasks, more pain, more chronic conditions, more drinking and more psychiatric problems. So again, it seems like there's something going on with the aging boomers. So and part of it is in the spectrum of sort of poisoning, suicide, distress type of realm. So what in my work or stuff that I've done might maybe support this a little bit? So in NAMCs, we did a paper looking at trends in psychotropic prescribing from 2003, so 2003 to 2005 compared to 2010 to 2012. And so basically the take-homes from this are, so we looked at these patients stratified by whether or not they had a diagnosis of depression, anxiety, insomnia, dementia. And for those diagnoses, there was no increase in benzo prescribing. If you look at patients with pain, big increase in benzo prescribing. And again, this pesky category of no mental health or pain diagnosis, increase in benzo prescribing. So again, there's something like a signal there about prescribing that's increasing that's not tied to a specific mental health diagnosis. So then this was another paper where we looked at psychotropic polypharmacy, which is like my personal clinical pet peeve. So again, looking at older adults, so 65 and over, visits to providers of any specialty, looking from 2004 through 2013. And so the take-homes from this are basically that it tripled over that period of time from 0.6% to 1.4% of visits. And again, when you look by diagnosis, it's not going up for any of those diagnoses. Who it's going up for are people with pain and people with no mental health or pain diagnosis. I should say the polypharmacy basically includes the psychotropic classes you would think of along with opioids included in the mix. So not surprising that pain went up. Okay, so This is this Bach-Huber study. We looked at just in the first couple of slides about trends over time, but specifically focusing on how they split it out by age group. In general, you see the biggest change in this 45 to 64 group. And then so my own work, so two things about this that are interesting. So first, I'm wondering like, okay, so at what point is this midlife group gonna cross over and exceed the amount of use in adults over 65? The other thing that I'm wondering is, this study, and most of these studies, are looking specifically at prescription benzodiazepine use. So they're not accounting for misuse at all. So what happens then, A, can we update the prevalence, but B, can we also incorporate what happens if you take into consideration misuse? So use by people who don't have a prescription, or people who are maybe have a prescription, but they're taking it not as it's prescribed. And so basically what happens is this. So the orange is misuse, the blue is prescribed use, and the green is combined use overall. So the first things to look at are the 50 to 64 group now is at or exceeds the greater than 65 group. So it looks like maybe older adults, the 65 and over group, is now being overtaken, and the lead in benzo use is going to basically the baby boomers. So in 2015 to 2016, basically this is all baby boomers with just a couple years here in this group. The other thing to notice is that, so I usually don't think about 18 to 25-year-olds, but if you are thinking about benzo use and you're only looking at prescription use, you are significantly underestimating the amount of benzo use if you are, again, only looking at prescribed use, because the prevalence of misuse is actually as higher than prescribed use in younger adults. And so you can see the overall amount of use in younger adults is way, way higher than you would think just from prescribed use at all. Okay, so if we buy into the theory that there's prescribing that's happening, that's kind of a signal, basically increased benzo use is a signal of distress. How might you look at that? So one way to look at that is there more prescribing in areas of the country that you might think have more distress? In this paper, we looked at it in socioeconomic terms. So looking at unemployment, income, education level. So this is a really cool data source. It's the Medicare Part D public use file. I found out about this from Kevin Kerber and Brian Callahan, who are two neurologists here. Basically, like, anybody can look themselves up. You can look up your clinic supervisor, you can look up anybody you want, and you can see in 2015, 2016, all of their prescriptions that were filled in Medicare Part D. They protect patient privacy, they do not protect the provider's privacy, and so it has Donovan Maust or Lauren Gerlach by name in this file, which is kind of cool and a little bit frightening. So anyways, we used this file from 2015. We ended up identifying primary care providers again. And okay, so we don't really, you don't have patient level data, again, because they're protecting patient privacy. What you do have is for every provider in the file, you have all of their claims for all medications. I was specifically interested in benzodiazepine claims. And you have the total number of days that they prescribed in Part D. So we basically use this measure of prescribing intensity, where we looked at the proportion of prescriptions that were benzo prescriptions divided by the total number of prescriptions. And so for the county analysis, we basically added up all the prescribing from all the providers in a county and looked at how much of that prescribing was a benzo divided by all of the prescribing. And this is the map that you get. Which again, doesn't really seem like it's a random distribution. And then when you look by county characteristics, you find that counties that have lower education, higher unemployment, and lower household income have higher intensity of benzo prescribing in those counties. So in a sort of bigger picture way, how do you think about figuring out a map that looks like this? Do I think that this reflects evidence-based prescribing? I'm not sure. And so you could think about it at multiple different levels. So first level is, maybe it's about the patients. And so this is a letter that Lauren Gerlach had published in JAMA Internal Medicine, where this is a different sample, different study, but we were looking at a community population of older adults in Pennsylvania. We looked at who got a new benzo start, and then who a year later would we consider a long-term user. And we defined that as they had a medication possession ratio, or the percentage of days in the year that they had a benzo prescribed was 30% or more 1 year after they got that prescription. So first, I just would point out the mean age of these adults getting a new benzo was 78.4, which is concerning. A quarter of them became long-term users. And if you look at the predictors, so very bad sleep, not so surprising, no association with depression, anxiety, or pain, surprising, but white race and size of the initial supply. Those, I would argue, in sort of a rational evidence-based system should not influence whether or not somebody is on a benzo for a year. So then let's think about actually what's happening with providers. So in that particular study, we didn't have enough patients per providers. We basically had as many providers as patients. So we couldn't really say much about that particular provider's habits. So in this study, we actually could do that. So you'll remember the data originally is at the individual physician level. So we could actually look at an individual person, Dr. Maust's prescribing, and out of all the Part D days that he prescribed, what proportion of those were benzo days. And so we just split them into quartiles. So about 4% of prescribing in the high quartile were benzos compared to 0.6. So that's just like a 6-fold difference in the individual providers when you look at it by bottom to top quartile. So if you look at the things that predict who is in the top quartile, who's a high intensity benzo prescriber, female providers had much lower odds of being a high intensity benzo prescriber. High intensity opioid prescribers, 4 times higher risk of also then being a high intensity benzo prescriber, which is not so surprising, but again, concerning. And then this one was a little bit odd initially. So if you prescribed a lot of antibiotics, you were also more likely to be a high intensity benzo prescriber. So this, I think one of the reviewers thought we had screwed something up with our denominator. And so even if we changed the denominator and changed it to total patients in the panel or total number of medications prescribed, or it didn't matter what the denominator was, the finding remained. And I was talking to Allison Lynn, who's an addiction psychiatrist and one of the co-authors on this, and we were saying that it's not that much of a stretch of the imagination to imagine that the provider that would take time to explain to a patient with what they think is a viral upper respiratory illness that they actually don't think that prescribing an antibiotic is appropriate. It's not a stretch to think that that same provider is the same person that's just going to maybe listen to a patient who's feeling anxious or talk with them about some sleep hygiene rather than prescribing them a benzo. So this ultimately suggests that it's very much about the individual provider that a patient sees. That's a big determinant of whether or not that patient gets a benzo or not. So then finally, how do we think about communities? The community influence on prescribing. And so here are 2 examples that hopefully you can kind of sort of make out. So this is the state of New York. You will notice that almost all of these counties are white, which is the lowest quartile of prescribing intensity. So in the late 80s, New York had this triplicate prescription policy that basically increased the administrative burden of benzo prescribing, and so I think actually you couldn't prescribe any refills. So they basically went above and beyond what the DEA required them to do, and it's continued even now in the era of electronic prescribing, but basically the administrative burden of prescribing a benzo is much higher in New York. So it's not that these patients aren't anxious or they don't have insomnia, it's because of the system that's set up in the state of New York. So this one is a little hard to figure out what state that is, but hopefully you can tell it's Virginia. So I'm familiar with Virginia because I did most of my growing up there. So the coastal areas, so the DC suburbs up here and Hampton Roads, down here, you can see relatively less intense prescribing, and then it's just like a gradient towards the point of the state in Appalachia, which is a more socioeconomically depressed state. So anyways, I think of these as very much suggesting that there's something about the community, whether it's a policy or whether it's the socioeconomic characteristics of the community that are also associated with prescribing. Okay, so finally, not quite finally, but we're getting to the end. So if you're thinking about the natural history of benzo use, there are really kind of three key points. So there's the new prescription, there's the transition from a new to an ongoing prescription, which is what Lauren looked at, and then there are the chronic users. And so thinking about reducing benzo prescribing, really you have to think very carefully about these three different domains. And in particular, your goal is to prevent this stage from happening. So there was a study that a psychologist who is now at Yale, but at the time she was in the Philadelphia area, did, where they identified patients in primary care settings who were prescribed chronic benzos, and they talked to them and to see like what's their belief system around their benzos. And there were some quotes in the paper, I don't mentally think I would have survived without it. I'm not going to experiment with myself at this age. My physician wouldn't have given it to me if he thought it was going to hurt me. So that's actually a big issue, especially if you're like a new provider taking care of somebody who their patient, who their old doctor prescribed them a benzo for a long time. This can be a little bit tricky. And then it makes me feel like I want to go on living. I mean, how do you even talk about that? Like that's a hard discussion to broach the topic of taking away something that makes people want to live. So then in a separate paper, they talked to doctors. And these are the things that the physician said. If it works and she doesn't abuse it, who cares? It's literally like taking candy from a baby. I can't lose patience over this. And let's just pause and note the ageism in that statement. And then finally, it's just so much easier to prescribe something and walk away. So I will always point out when I've given this slide that I'm sure that providers in Michigan would never say something like this. This is just those people in Philadelphia. And I'm joking, please. But anyways, chronic use is like a big issue. So this is one of the last big intervention studies that's been published. This is the geriatrician that did that review around the cognitive effects of benzo exposure. So it's called the Empower intervention to reduce benzo use in long-term users who were 65 and over. So they identified 2,700 potentially eligible participants. All the intervention was mailing them educational intervention. The patients didn't have to go anywhere, they didn't have to do anything, they had to say, yes, you can mail me some material. 11% of patients consented to be in this study. It is really, really hard to convince patients to be in an intervention study to stop a medication that they think they have to live. So what's the one bright spot on the benzo front? Is the VA. So this is work I got to do along with Eve Kerr, who's part of this Choosing Wisely initiative, and so they've been looking at low-value care in multiple different settings. And so in this, I'm just showing you the VA data, but this was a kind of a funny paper that compared Australia, it's like Australia, Ontario, and the VA. But that's who we had, and JAGS was okay with that. So anyways, so this is looking at prevalent use. You'll note this axis goes up to 10%. This is incident use or new use, and this just goes up to 2.5%. But anyways, use has gone down in the VA, which is really interesting because there's nowhere in the US that use has gone down. So a friend of mine, Ilse Wiekers, is actually a geriatric psychiatrist and was a Robert Wood Johnson clinical scholar at Yale. So she runs this thing called the Psychotropic Drug Safety Initiative at the VA, where they basically have a bunch of different measures focused on improving the quality of psychotropic prescribing, but one of the things that they've been focusing on since they started, so about 5 years or so, has been focusing, one of the specific measures is around benzo prescribing to elderly veterans. And it's not intervention. So there's no issues of patient consent or patient randomization. It's basically like the way the VA works sometimes is you can get sort of a top-down administrative mandate, like you should focus on this, please do this. In this case, it's left to the facilities how they want to address it. But again, some facilities clearly have been very successful in being able to bring use down. So to recap, what are benzos? So they get you out of a cage of brooms by enhancing GABA activity. The epidemiology of use is that it's going up, especially among late middle-aged white adults. What's the evidence base for benefits and risks? Hopefully I have convinced you, if you needed any convincing, that the risks definitely outweigh the benefits, especially in light of alternative effective treatments. What actually drives prescribing? Again, hopefully I've convinced you, it's really largely not the presence of specific clinical diagnoses in patients. And finally, what do we know about interventions to reduce use? Not a lot, because patients don't want to be in these studies. And so then that brings you to what is really the final slide, which is basically what I'm doing for the next 4 years. So the first thing we're doing is, so I was so enamored of this map that I included it on a specific aims page that NIDA ended up funding. And the first aim of this project is to really figure out, like, what are the determinants of prescribing at the patient, provider, and community level, both in terms of starting a new benzo, and then who among the new starters are the continuers, and what really drives that, because you have to understand that to understand how to actually try to reduce use. So that's will be the first part of that project. So the next thing we're doing is actually a study in the VA to understand. So part of this, the PDSI program that I told you about in the VA, again, it was left up to facilities to decide what they wanted to do. So you could imagine a facility that had a top-down approach where basically the medical center director said, Dr. Maust, these 5 patients are on benzos, 6 months from now they need to be off. You could imagine that approach versus something like the Empower intervention, where they essentially mailed patients education. It was a much more sort of education-oriented, let's partner with the patient and work with the patient to have this be as minimally traumatic as possible. And part of the reason how I sold this is, again, that intervention studies, we just don't know. That study, only 11% of patients randomized consented to be in that study. And so how generalizable is that? How applicable is that really to all older adults in the community? We just don't know. There's no way to know. And so then the final thing we're doing is, like, what happens with a really blunt policy change? So when Medicare Part D was introduced, it actually did not include coverage of benzodiazepines. And then because of advocacy and people saying there's an undue financial burden on patients and this is limiting really important treatment for some people, actually coverage was turned on in 2013. So this is from Optum data, which is Medicare Advantage, and you see 2011, 2012, then across this red line you have this huge jump in the number of people who have benzos. So what happens when you turn on the benzo switch? And so in work with Amy Bonnert, we're looking specifically at the rate, what happens to rates of falls and rates of overdoses among the Medicare Advantage population using Optum data. And I just put a star by that. None of the injury center PIs are here, but I know that that deadline is this coming summer and it's not 2022. So I just wanted to reassure them. So at 4:50, I will stop. I will just say some thank you to this group of analysts and project managers who are the only reason anything gets done. All the collaborators, in particular to the IHPI Data and Methods Hub, because that NIDA grant would not have happened without the support of the IHPI Data Hub. Phyllis, thank you. Also Fred Blow, so any of you who know me and what my K was on, this is not in any way related to what my K was. Don't listen to that if you're working on your K. But Fred Blow, who was one of my mentors, is a mentor, is a big fan, proponent of sort of research, portfolio diversification, and it has worked out very well, and he was a big proponent of the benzo line of work. So with that, I'll say thank you and take any questions. Yeah.
Curious.
Hi, Ted Seiger. Donovan, I was wondering if the map that you showed, if you've looked at like the density of psychologists and psychiatrists who provide CBT, and whether that map looks very similar to the map that you showed in terms of benzodiazepine use.
Right, so that's a great question. We couldn't specifically look at CBT, but what we did use is this thing called the Area Health Resources File that basically gives you county level supply of providers. So we could adjust for the number of primary care providers, the number of psychiatrists, whether there was a community mental health center. So we basically, again, that's not specifically whether they're offering CBT or not, but at least we could account for, do these counties even have mental health providers or not? Yeah. So that was not in the map, but in terms of the, like the county level associations, those were all adjusted for the provider supply.
Hi, Donovan. Thank you. Julie Bynum through People Who Build. I'm excited to be here and learning about what's going on. Donovan, I'm always struggling with the question of which came first. Mm. So when you're looking at, especially the studies that are around cohort change, cohorts of different experience over time, like economists would call it, is it demand or is it supply? Is it hammer or nail on the physician side? You know, doctors have hammers with nails, so when somebody comes in it with anxiety, they give them drugs. And over time, if we trained the population that that's what should happen when you have, and then the current cohort of providers say, but the patients want it.
Right.
But in truth, we've trained them, which makes
Right.
your antibiotic finding absolutely predictable and exactly what I would have expected, because that is a very similar construct that we have trained people that they need antibiotics, and now we're trying to untrain them. Is there something, you know, I know you have no data there, but what are your thoughts about how to undo some of the population training?
So that's a great question, and frankly, as a psychiatrist, I think about that a lot. I think the pendulum swung so far to sort of this biological model of psychiatry. I think it's kind of magical thinking sometimes, frankly, both on the parts of patients but also on the parts of providers around like the wondrous effect that the medications can have. So I don't have a great response other than to say, like, I definitely agree. And I don't know, I definitely agree, and I just don't know. So one of the other, anyways, I'll stop there.
It suggests a multi-pronged approach
Yeah.
is the absolute necessary.
Right. So I'll be really curious, say, for example, in the VA, what we find that facilities did that actually seemed to work. And part of what we're going to do in the second aim of that is actually talk to some patients that we've identified as having come off of a benzo and basically say, like, did they make you miserable? How did they do it? Was it essentially to figure out, like, are there certain things facilities did that patients found acceptable versus other things that was just like torture of the patient?
Hi, I'm Charlie Townsend. I'm a PhD student in health policy and sociology. Thanks for your talk. The deaths of despair research focused predominantly on white population, the white population in the US, or a subset of them. And also we know that for opioids, there are racial disparities in prescribing, particularly for chronic pain. So I'm curious to hear from you about sort of, from what you're aware of the role that race has played in trends in benzo prescribing and mortality, and also whether you saw that that was an important predictor at the county level data that you looked at.
So the county level data, I'm trying to think. Actually, I don't remember at the county level. It's like a little bit of a muddle to look at, you know, the race and ethnicity at the county level. So that there was not, if I recall, a strong finding at the county level. From the individual level, absolutely, white adults are more likely to get prescribed benzos. You see lower use among ethnicities. When you look at the change over time, it's more growth among white, non-Hispanic patients. The Bach-Huber paper that I kept coming back to, that I showed you, the three panels that had the split out by age and like the prevalence, the milligrams per 100,000, whatever, an overdose. If you look at that, he had another table that was split out by race, and white race is always at the top. Interestingly, locally, we did just a small intervention with a couple clinics. And the two clinics that serve sort of underserved minority populations had the most aggressive controlled substance policies and the lowest prescribing of these medications. So it's a really interesting instance where I think there's absolutely bias on the part of providers, I'm a little bit not sure how to think about it in the sense that potentially these patients then are not being exposed to bad medications, but I think there's absolutely provider bias around who's getting these meds.
Hi Donovan.
Hi Dan.
So for everybody else, I'm Dan Berlin. I'm from Medicine and Addiction, and Donovan and I have met on this subject before. It was a great talk.
Thank you.
And, I'm going to be hitting you up for a couple of slides. So I think that this problem is a lot about availability, whether it's because we're loose prescribers or because insurance coverage changed. And it seems like the top-down hammer approach, as demonstrated by VA directives and by in the opioid world, the CDC guideline of 2016, are the only ways to produce changes in behavior by prescriber, because gentle approaches for 10 years before that did not change opioid prescribing. And it's interesting because the latest data I've seen is that actually overall opioid prescribing has not fallen that much in response to the CDC guideline. But all we're talking about it, and if prescribing falls, we stop creating these patients, after about a generation, patient expectations will change and we will reverse some of these problems. So, that said, you have data coming this summer. What's it going to take for us to go to Atlanta and declare from the CDC a benzo epidemic?
Yeah, I mean, I think that probably didn't need an answer, but I think part of the issue is I really think sort of the opioid issue has sucked a lot of the oxygen out of the room, and I think providers are trying so hard and systems are trying so hard to address the opioid issue. I think it would almost feel bad putting this on top, even though I do think it's essentially like an accelerant to what's going on with opioids.
But we do have their attention now.
Yeah.
And recently through EPIC in the U of M system, we've made it much harder and more thoughtful about co-prescribing by making them have to do several dozen other clicks to get through it.
Yeah.
So, and acknowledge that they're probably doing something dangerous and should be prescribing naloxone. And so I think we have their attention and this is the time.
Thanks, Donovan, for a great talk. This is more of a clinical question, but for patients and providers that are chronic users, the patients, and are interested in coming off, do you have advice about how to think about weaning patients?
Yeah.
You know, in using these medications chronically
Yes.
for insomnia or anxiety?
So very, very, very gradually is the main thing. You know, all of the findings show a dose response. So in my opinion, any type of reduction in the dose from a harm reduction perspective is a good change. So I think the goal is basically that it's very, very incremental, and so whether that means working with the pharmacist to see like how can we dispense this, formulate this, so that the dosage reduction in the first, month is at the very most would be like a 25% dose reduction. Typically in taper schedules, the first 50% reduction can be relatively faster, and then the tail you want to do much, much, much more slowly. I think the worst case scenario is having somebody try to taper too quickly, experiencing bad withdrawal, and then they're like, nope, I'm never doing that again. I had a patient in the VA with PTSD who I thought, you know, the benzo wasn't the greatest idea, and basically he had been admitted to a hospital, they didn't restart his benzo, his wife was like, he was a monster when he didn't get his lorazepam, no taper, never. So I think a bad taper experience will linger for a long time. So the way to not have that is to be super gradual, and also to talk with patients that, so I think patients can interpret, they feel like when they reduce their dose, maybe their sleep is worse and they're feeling more anxious, and they interpret it as the underlying condition is reappearing when in fact it's withdrawal symptoms. And so if you work with them to sort of sit through the period of withdrawal until those symptoms go away and they're ready for the next tiny reduction, so very, very slowly is the best way to go.
Great, well, we're ready at 5 o'clock, so I want to thank Donovan, who's joining me in thanking Donovan for a great talk. And I hope many of you can